Well, thank you, Dennis. Another excellent and well-researched presentation, as you've always done. I appreciate the time and effort you put into it. I'll give you a minute or two to relax and charge your glass. I know there'll be lots of questions. So while we wait for that, just a couple reminders, folks. You've been on mute all through the lecture. Thank you for your cooperation. We'll continue doing that. And I'll ask you to send me your short, concise questions through the chat box, and I'll present them as they come in. While we wait for that, we'll also be doing our regular polling question, which will pop up on your screen in a minute or two. Please take a time to answer that. We're looking for the best way to support you as our members and potential new members. We've asked questions in the past like, how many of these lectures have you attended? Would you be willing to pay a modest fee for people who are non-members? Tonight, I think we're asking, are you now or have you been a member of our academy? What are the things you want us to do for you? Because clearly in-person meetings are not going to happen this calendar year, but we do want to continue to be a service to you as the Academy in Canada. So take time to answer those questions in a minute when they pop up. Just a reminder for any of you who are new, this is our 9th webinar. You'll find tonight's webinar and all past subjects fully recorded on our website and also on our YouTube channel. They'll be ready probably by the weekend, and all of them are available for you to watch at your leisure in any order you require. Also, you should know that the lecture and the question and answer are separated. Otherwise, you've got a 90-minute to 100-minute video, and some people just want to get to the question period or reread the lecture. We have a schedule right up to the 2nd of June already. The dates, the speakers, and to some extent the titles are already on our website. We are always open to more suggestions. Our big concern is, are we going to continue this through the summer? When we started this last fall, I thought this would last 2 or 3 times. We're now at number 9. Our attendance is growing. Our reach is broadening. We're reaching more folks. So if it's something you'd like us to do, we will continue this through the summer because, as I say, we're now up to June the 2nd. I think that's all I need to say. So I'll start sending in your questions, please. And while you think of that, I'm going to pop up the polling question, which tonight is, and I have to launch it, are you a current member of the CASDD? And you can start answering that now, please. This is like election nights. The results are coming in very quickly. Dennis, get your whistle wetted, and hopefully we'll have some questions coming in fairly quickly. I'm just going to move that over here, and I'm waiting for people to send me questions. We generally have a host of people who have very thoughtful questions, so I hope I'm doing this right. You also need to know, folks, that you can contact myself directly or Bianca, our Director of Communications, for any assistance you might need in spreading our word. As you know, I'm a dinosaur when it comes to social media, so I don't even pretend to know how it works, but most of you do understand that part, and we've asked a number of times to spread, like, share, or whatever term you might use for spreading the word, because email obviously is quite limited. If you don't have your address, we can't reach you. Bianca, while I'm waiting for the poll to end, do you have any words of support, or do you have anything you'd like to share with the folks in terms of what you've experienced since you've been with us?
Sure, I'm just happy to be here. Thanks, everyone. And it's so nice to see a lot of you returning to the webinars. I guess I'd like to stress that if you are wanting to see more of a particular type of content, then please don't hesitate to contact myself or David and let us know, and we'll be happy to try and add that to the website or whatever program that fits. And then also just a reminder to let me know if you haven't received a certificate. I believe I'm almost up to date. A certificate of participation for your CE. My email, you can reach me at info.cacsdd@gmail.com. So again, please don't hesitate to ask me anything, even if it's social media related. I'm happy to help. Thank you.
Okay. Thank you, Bianca. And maybe just to, oh, here come the questions. Good. Maybe just to fill in on your comment on CE, because we're a nationwide academy, the rules, as you all know, are provincial and or territorial. My understanding in Ontario is that all of our certificates have been what are called category 3, in other words, the lowest level. I'm not aware that colleges are not going to have to rethink it all, because everything that we've been doing in the last year has been virtual and not in person. So keep collecting them and submit them as you would, but I would not promise it to be in any more than what we call a category 3. In other words, 1 point per hour. Okay, so if you're ready, Dennis, I see questions coming in, and my big old eyes are going to make me blow this up. So in order of receipt, here are the questions. Are there soft palate lifters that can be attached to the oral appliance to help maintain the airway? Did you hear that, Dennis?
Yes, I did.
Okay.
There have been in the past. There is still one appliance that is FDA cleared to do that, but that's not exactly what the intent is. You don't want to hold the soft palate up. You want to allow the soft palate to accommodate enough of a retropalatal opening so that the nasal breathing is well accommodated, not to force the patient into a mouth breathing pattern. I would say that probably the Pillar procedure, which was the Dacron wound rods that were placed in the soft palate for what was called palatal stiffening, may have been an attempt to create less flutter, thus reducing snoring, and may have actually helped to address this concentric collapse. But I don't think you want to be pushing the soft palate up and back. You want to let it come down to some degree.
Thank you. Second question, is there data on OAT success with, for example, the dimension of the lateral wall? Asking about the potential for outliers.
There is not. This would be a very, very interesting, it would probably be a retrospective study, but this would be a very interesting thing to look at as to the, like I said, I'm sorry, I didn't mean to do a dangling participle there. This is something that would be interesting to look at retrospectively to determine if there actually is a lot to this as to what and how it plays in without having to do endoscopy. I would say that based upon Remmer's article, which I cited, where I showed you the width with the little red arrows, that was out of his article in the American Journal of Respiratory Critical Care Medicine. They looked at it as far as forecasting sleep apnea. So I think that we could probably say that may also help us to forecast whether or not the risk for oral appliance success was good or not so good.
Okay.
I don't know if that answers the question.
Well, we'll see if we get one come back. I'm ready for more questions. I know a lot. Hi, how are you doing, Sharon?
Good. Dennis, first off, really great talk. I just wanted to introduce myself because I do drug-induced sleep endoscopy here in Toronto. And basically my fellow created the vote classification with Eric Kazarian. So a lot of what you spoke about resonated with my practice. And I guess I just wanted to add to some of what you spoke about with a lot of patients that I see that come to me that have had oral appliances, and the oral appliances can be working well, but they still have residual snoring, for example. When I do drug-induced sleep endoscopy, what I see with a lot of those patients are that they do have without, so what I do is the jaw thrust maneuver, right, to simulate what the oral appliance would do. And prior to doing the jaw thrust maneuver, I would see that these patients do have a concentric collapse at the level of the palate. And then when the interesting thing is that when we do a modified jaw thrust maneuver on these patients, the level of the tongue opens up beautifully. So you can see that the oral appliance is doing what it needs to do. But then the palate, sometimes the shape or the configuration of the palatal collapse changes. So it actually changes from a concentric to an antero-posterior collapse. So for those patients, typically the treatment that they need is combination treatment. So they have their oral appliance, but they still have that AP collapse. You can see the vibrations that sometimes get even louder with the jaw advancement. So they then would be great candidates to have either, invasive, say start off with less invasive palate procedures, like what I do are radio frequency. So the patient's awake and you apply radio frequency just to stiffen up the palate so you don't get that vibration, all the way to invasive surgeries like the UPPP. The UPPP, you'll see a lot of the shift in the philosophy for ENT right now is that we're moving from resecting a lot of tissue in the palate, and I'm sure Dr. Kazarian would have spoken to you about this, to repositioning or reshaping the palate. So right. You're repositioning the muscles to get that lateral wall opened up, for example. But it's very interesting when I do see that for patients that, yes, the oral appliance is doing 90% of the job, but you need that additional treatment modality as well.
Have you found that these same patients are overweight or have any rostral fluid shift or have the narrow palatal airway?
So in terms of the overweight, because the criteria I use for sleep endoscopy is that the BMI has to be 35 or less. So technically, yes, you're still in the obese category, but they're not over 35, which I know for surgery, sometimes that's where you get into patients who are really obese and you see more of the rostral fluid shift. And the next criteria for sleep endoscopy too is that my ASA classification or the anesthesia classification is usually level 2. So patients may have comorbidities, but they're controlled. They have controlled hypertension or controlled diabetes. Yeah. I find a lot of the patients who have the rostral fluid shift would be the patients who've had an MI, a heart attack in the past. Their heart isn't working as well as it should, right? So that they experience a lot of the leg edema more so and would be more vulnerable to that rostral shift. So I don't see that as much in my population because I'm selecting out those patients per se.
Right. Good. Very helpful.
That was a good interchange, and you never know who's going to be in the audience. So thank you, Sharon, for that. I now have another written question, Dennis. If the patient has a narrow posterior pharyngeal width and have a BMI exceeding 25, how much weight might they need to lose before the patient feels a noticeable difference in the way they feel in the morning? Do I need to repeat that?
Two different, you're looking at two different factors that are not mutual. They affect things differently. I mean, the lateral width that's narrow is not going to improve with weight loss. It's just not going to go away. That's an anatomical consideration. Whereas the weight loss is something that is environmental, we'll call it. So you're looking at this whole relationship, between endotyping and phenotyping of the patient. So the patient still may require some other adjunctive procedures to get to a satisfactory result. The weight loss will help, but it's not going to be the total solution because you've got an anatomical consideration as well.
Okay, thank you, Dennis. Just so you know, the polling question is still open. We have a number of people who have yet to vote. It's a very simple question. Are you a current member of our academy? Yes or no? I'm looking for more questions. Normally we have quite a few. Hopefully we haven't lost people. Bianca, is there anything technically that I'm unaware of? We seem to still have a number of people signed in.
No, everything looks good on my end here.
Is my voice getting carried across okay?
Oh, I see another question.
Another question coming in. Oh, good.
Yes.
I guess the threat of cutting off their membership. Okay. Do you know anything about the use of a new type of laser, a CO2 laser, to stiffen the hard palate? This might go to both Dr. Bailey and Dr. Morong. Let's start with Dennis first. Do you know anything about the use of a new type of laser, CO2 type, to stiffen the soft palate? Dr. Bailey first.
I have not seen any literature on that whatsoever. The only place I've seen the use of the CO2 palette is with this concept of posterior tongue tie.
Okay. Dr. Morong, do you have any?
So there is a treatment now. It's called Nightlase. So you would see that a lot of you'll see it a lot in clinics now. As Dr. Bailey said, there isn't a lot of evidence for it. So going with anecdotally, patients who tend to have either primary snoring, so they don't have a lot of sleep apnea, or if it's anything mild sleep apnea, there has been some improvement seen, but usually they need the laser with myofunctional therapy to get overall tone improved in those patients. I don't use the laser. I'm one step up using radio frequency, right? Where you're actually, it's more invasive for the patient. The Nightlase, there is, there's no pain. You don't need a physician to actually do it. So yes, it may work, but you need to give the patient realistic expectations that they may need adjunctive treatments as well, or they need to have a step up to radio frequency. And if that doesn't work, you're going up the line to more invasive procedures.
Thank you, Dr. Morong. For those of you who have joined us late and may have only been involved with this recently, Dr. Morong is a new, and with all deference to Dr. Bailey, she called herself an ENT, and that's easier for me to say than that Odo word. She's new and in Toronto and has been a very vibrant supporter of these webinars and will be a presenter herself in, I think, 2 or 3 sessions from now. So Sharon, do you have anything you would like to throw out to interest folks in coming, or is there anything you'd like to tell us about your practice? How do you see us working together? Because as you know, that's the main thrust of our academy, is to build a big tent and gather all of us under it. So we're so happy to have you with us. So without putting you on the spot, sell yourself a bit here tonight.
Oh, thanks for having me. I'm glad I was able to know that this group is here. It's a learning experience for me too. And pretty much, I'm in a unique position where I do ENT or otorhinolaryngology, and I'm a sleep physician as well. So my fellowship was done in Amsterdam. And in Amsterdam, sleep medicine is practiced in a totally different way, where pretty much it's purely collaborative, where you have every specialty basically sitting at the table together, discussing a patient to figure out what's in the best interest for that patient. And usually the starting point is, you do a history, a physical exam, but then you move on to sleep endoscopy, right? Because then from the sleep endoscopy, you get a picture of what the patient's airway is like when they're under sedation, and exactly what Dennis spoke about in terms of endotyping. You can look at the upper airway collapsibility, you can assess tone, see if there's any retropalatal obstruction. So we would have dental professionals at the table, we'll have the oral maxillofacial surgeons at the table as well. So, coming back to Toronto, it's been different because every group seems to work in their own silos here. So my hope is that, I would be able to interact or collaborate a lot with dental professionals, either pre-appliance. So, as Dr. Bailey spoke about, with having a trial appliance first, to use that to see if, a dental appliance alone is enough, or they need some adjunctive treatment as well. Or if you have a patient where you've done everything you can, you've reached a certain point with the oral appliance, and you're not sure where to take things next, that I can be of help with the endoscopy to shed some light on where to go next.
Thank you. Dr. Bailey, of course, is expert in the States, and he also knows that in Canada, it's a socialized medical system, and dentistry gets virtually no compensation from the medical system whatsoever. So, Dr. Morong, what do you know about how different, say, Eastern Canada is in terms if you were practicing in Quebec versus Toronto, or perhaps the Maritimes, or another Western province? And without being too personal, did that help you choose which province you landed in to do the work you're doing now?
No, well, I left Toronto to do my fellowship. So Toronto's always been my home base. It's difficult to compare provinces because there are only 3 of us in Canada that do drug-induced sleep endoscopy to begin with, right?
Wow.
So
Only 2?
there isn't
3.
much comparison. We all try to maintain a standard in the way that we approach patients. What I can say is that part of what makes things different is not the sleep endoscopy, but in terms of sleep studies, right? So the way that things, there's compensation here. One, patients need to have a level 1 in-lab sleep study that's covered by, funded by the Ontario, by OHIP. So then it's less accessible for patients who may not want to go into a lab and who may want to have home sleep studies done. So that's a bit of an access issue for patients. And then 2, once a patient has had a sleep study, because I'm a sleep physician as well, when you do talk about different treatment options for patients, CPAP is 75% subsidized by the government. So even if a patient may want to investigate through endoscopy or just to look at alternate options, sometimes they're kind of backed up in a corner where it's like, well, in terms of affordability, I'll go for CPAP, and it's a bit of a shame because it works really well for patients who can actually use it. But for patients who can't, it becomes a very frustrating journey for them, right? So that's what I'm not sure in the other provinces. I feel like in Ontario, it's definitely, other provinces, there are home sleep studies and there are more options. But in Ontario, I think that right now we're still a bit restricted on that side.
I've heard it referred to as the black hole of healthcare in Canada, meaning Ontario. But I don't know where that quotation came from. I have no idea. We have another complex question that I think would be appropriately addressed to both Dr. Bailey and Dr. Morong. So Dr. Bailey first. I may have to read this twice. It's quite wordy. I have seen a video of a device that resembles a reverse pogo stick. It's placed inside the posterior aspect of the tongue. It provides a spring-like action against the pharynx. It increases the 3D airway space in the oral pharynx. Are you familiar with this device and the procedure? The patient was morbidly obese and CPAP wasn't effective. Dennis, do you want to start off with that? A pogo stick. It's not even in quotation marks. I'm not sure what it is.
I have no clue what that might be. I've never heard of such a thing. I know that there was an appliance. I think it was called the Garcia appliance. It was sort of a fluke that showed up on the internet years ago. And it looked like a combination oral appliance with a, a speculum to do an intubation. It was horrific. I can't imagine somebody putting that in to pull the tongue forward. But as far as a pogo stick type combination, I'm afraid that I'm at a loss to tell you that I know anything about it.
Okay. Dr. Morong, do you know anything about this?
No, I'm not sure. There have been so many different devices over time that have been used, either using spring techniques, spring loading techniques, or magnets that have just not worked. So I'm not familiar or not sure about that particular device, but I know that devices that are placed in the tongue, because the muscle is so strong that usually devices snap, or they're not able to go against the force of the tongue muscle. So they're not very long lasting, and that's why they haven't worked thus far. But I'm not familiar with this particular one. For example, if you do have a name,
Well, I do.
for it,
I
I'd
do
love to
actually. Yeah,
look it up.
sorry to interrupt you, but I just see that we've got an add-on to the question. Dr. Catalano was the ENT who placed the device. He may have been in India. Dr. Catalano, Catalano, Catalano. Ring a bell with either?
No,
No.
Okay.
now this is going to bother me. I have to look this up tonight.
We don't want you to lose any sleep over worrying about, if you know what I mean.
Goodbye.
Okay, I really appreciate your time. We're moving on to almost 90 minutes. I do not see any other written questions. We have at times open the mics for people who want to ask an oral question. I'm happy to do that. While we wait for that, I'll share with you the polling. Tonight's question, are you a current member? It's almost 50-50 split between yes and no. Our challenge is to encourage more people to become members so that we can continue to provide this service. I almost sound like a PBS TV commercial. If you want this music, join us. But that's essentially how this whole thing works, folks. So we would love to be of value to you if you can help support us. I don't see any other questions. I'll open the mic. Does anyone have a question they want to ask without typing it out? I'm hoping I'm reading them well enough, but if anyone is still with us and wants to ask a question, please indicate and we'll let you bring it orally. If that doesn't happen, we may just call this to an end tonight. I'll give us another minute or two. So while I'm waiting for that, don't forget our next webinar in 2 weeks. Dr. Chris Lettieri, who was also with us, I believe, in 2017 in Toronto. That was the meeting when it actually happened on Remembrance Day. And as a former Canadian military dentist, I was proud to have, I think, 5 or 6 serving members of our Canadian dental forces, and with Dr. Lettieri, who also came from, I believe, California with his full military uniform, put on an excellent Remembrance Day service in the middle of our scientific program. He is going to be presenting next, and the subject is, when the noise stops, or when the snoring stops, is there still OSA? And those of us who do this all the time will probably relate to the question. I don't need to come in for a test, doc, because my wife says I'm not making any more noise. She's happy, so I don't need to come in, right? And of course, you try to make them understand that if you can't test it, you don't know. So he's going to hopefully shed some light on the concept of how do you know you've treated the apnea if the only measurement is the noise that may or may not be coming from you as measured by bed partners or family members or golfing buddies or ladies who go shopping. Oh, we don't do that anymore, do we? When ladies get back to go shopping and men go hunting. So that's what's up next. Dr. Morong, I think you're presenting early in April.
Yes.
And do you want to talk a bit about what you might be talking about? Is that too soon to put you on the spot?
No, I think I'm going to expand on what Dr. Bailey introduced with sleep endoscopy. I don't think a lot of people,
Okay.
I said only 3 of us in Canada do it, so it'll be a good venture to show some videos, hopefully, of the endoscopy and just talk about collaboration.
Right. Would one of the other 2 be a man who lives in London, Ontario, where I am?
Yes.
Oh, wonderful! Wow, I'm gonna have access to 2/3 of the Canadian dice doctors. That's incredible. All right, I don't see any other questions either verbally or written. So I think it's appropriate that we thank Dr. Bailey again for a wonderful presentation on webinar. We'll love to have him back in person if we can ever start doing this again. I think, Dennis, the earliest this can happen will be the fall of 22. Is that how we're doing it? Yes, a year and a half from now. But thank you for your ongoing support. It's been a wonderful experience to have you. You come with so much information and you're just so comfortable with all the research that most of us haven't the time or the expertise to do. So thank you so much for 2 very good webinars in a short period of time. We appreciate that very much.